Hello, everyone, and welcome to the Foundation for Sarcoidosis Research Education webinar on musculoskeletal sarcoidosis. I'm Mindy Buchanan, Director of Patient Programs, and I'll be the moderator today. First, I would like to share and thank our sponsors, Mallinckrodt Pharmaceuticals, for their continued support for our awareness and education programming throughout the year. And next, I'll take us through a little bit of housekeeping to get us ready for the webinar. Again, this is a webinar, so we'll not be able to hear or see the audience members. This means if you use your raise hand function, we will not be able to respond directly. The chat feature works only as a direct message to speakers and moderators, so feel free to use this if you'd like to chat directly to us. I will be able to chat with the audience, and that's where I'll add any links discussed during the session, and we'll also send out the links in a post-event email. You may send your questions through the webinar directly, through the chat directly, or add them to the Q&A feature. The chat is not seen by others, but the Q&A feature can be seen by others. However, you have the option to submit a question anonymously if you'd like. If you have any technical difficulties, please chat me directly and I will do what I can to help. It's now my pleasure to introduce our expert for today's webinar, Dr. Pooja Singh. She's a specialist care physician, board certified in rheumatology at FSR Global Sarcoidosis Clinic Alliance founding member, Inova Medical Group. She has a special interest in the management of chronic rheumatologic conditions such as rheumatoid arthritis, lupus, osteoarthritis, gout, psoriatic arthritis, and vasculitis. Dr. Singh is dedicated to working with patients to understand their disease while helping them achieve an improved quality of life despite chronic illnesses. With that, I'll hand it over to Dr. Singh.
Thank you, Minnie. That was a very warm welcome. And thank you, everybody, for attending today's discussion. So we'll go ahead and get started. We're going to discuss the rheumatic manifestations of sarcoid today. So some of our learning objectives, we're going to be looking behind sarcoid in regards to the immunology. What are the presenting features of sarcoid, the manifestations? Epidemiology is basically who gets sarcoid. And then we'll focus in on the three topics under musculoskeletal sarcoid. So we're going to be talking about sarcoid arthropathy, bone sarcoid, sarcoid myopathy. And then we'll also touch base on some of the association of sarcoid and other rheumatologic diseases as well. And we'll briefly talk about treatment plans. So getting into the pathogenesis, so how does sarcoid develop? This is really kind of a complex interplay with immune cells and their mediators, and they all kind of come together to form this granuloma. So how does this granuloma form? So first thing is this foreign substance, and a scientist. Yeah.
Sorry to stop you, but your screen isn't shared.
Oh, sorry, hang on one second.
It's okay.
Let me go back. Get out of here. Thank you for telling me that.
Yep.
There we go. All right, there we are. That's kind of where we left off. All right. So just to kind of go back the learning objectives that I was articulating, and we'll go into the pathogenesis of a granuloma. So how do these granulomas form? So there's a foreign substance, and as scientists, we call these antigens, and it's basically found by the body's immune cells, and they engulf it. And that process is called phagocytosis. And once this is phagocytosed or engulfed, the immune cells kind of mash it up, and they process this foreign antigen into material, and then they present it on the outside, the surface of the cells. Then come along some cells called the CD4 T helper cells. If they see these foreign antigens on there, they recognize them, and they basically amplify the immune response. They basically call a whole host of other inflammatory markers and immune cells called interferon gamma and interleukin 12 and 2 and other cytokines, and they really upregulate this whole granulomatous inflammation. So then these macrophages, which are also immune cells, they kind of aggregate in response to this antigen, this foreign substance. Slowly, they form these things called epithelioid cells, which turn into multinucleated giant cells. And as the granuloma matures, these macrophages and epithelioid cells and these multinucleated giant cells really come together in a tight cluster to form this ball called a granuloma. So it's basically a ball of inflammatory cells. So some what we call extrapulmonary manifestations of sarcoid. So these are things outside of the lungs. It's widely known as a lung disease, but there's a lot more going on in sarcoid. It's very much a systemic disease. We can have skin manifestations in 25% of the cases. We can have eye manifestations causing inflammation in the eyes. GI manifestations like stomach, the intestines isn't as common, but liver involvement can be seen in up to 20% of patients. Neurologic manifestations can be seen in about 5%, and this is called neurosarcoidosis. This can affect the brain, it can affect the peripheral nerves that can lead to numbness and tingling. And it can also affect the heart in about 5% of cases. So who gets sarcoid? So it's most commonly we see it in patients aged between 20 and 40 years old. It's generally equal between males and females. In the United States, it's African-American predominant. In Europe, it's mostly seen in the northern countries. We do see cardiac involvement a little more in men, in the cutaneous, the skin manifestations and eye manifestations a little bit more, and so in women. And uniquely, it's less commonly observed in smokers. However, I don't suggest anybody pick up smoking in order to combat this disease. So moving on to the different types of musculoskeletal sarcoidosis. So first we'll go over sarcoid arthropathy. So this is a little diagram that basically shows us which joints can be affected. And you see when we say acute arthritis, that means something that has happened more recently, has kind of come on abrupt onset, kind of a fulminant swelling. Chronic arthritis has been going on for several months. It may or may not have swelling kind of associated with it or inflammatory signs. Much of the presentation in terms of the distribution of joints is very similar. And the red dots are mostly the acute arthritis, but the chronic arthritis can involve the same areas, plus a few other areas closer to the jaw bones and maybe even in the back there, the sacroiliac joints. This is a busy slide, but the take-home message to differentiate some of the manifestations and presentation features between acute arthritis and chronic arthritis. Usually the acute form is relatively common and self-limited, right? And we'll see that in a presentation called Lofgren's, which I'll go over with you all shortly here. We're usually not able to get any kind of joint fluid when in the acute arthritis presentation. But on the contrary, in chronic arthritis, if we do get joint fluid, we usually see that inflammatory predominance with more lymphocytes in it. If you were to biopsy a joint with acute arthritis, you probably won't see much of a granuloma or even an inflammatory infiltrate, but it could be very much present in a chronic arthritic joint. These are some manifestations. These are not specific to sarcoid. They can be seen in a variety of conditions. On the left, this is called Jacquard's arthropathy. This is very common to see in lupus, but this can also be seen in sarcoid. So you see how this is one of my patients, actually, her fingers towards the knuckles, closer to the fingernails are kind of curving and contracting down, they're flexed. This is actually reversible. Whereas there's other conditions where the joints are reversible. So if you push on her fingers, it will go back to the normal state and then pop right back. And so it's very much a tendon laxity. And this is called Jacquard's arthropathy. Can be seen in sarcoid, can also be seen in lupus. On the right here, we have what's called dactylitis. That is the medical term for sausage digit, if you've heard of that. This can be seen in things like gout. It can be seen in psoriatic arthritis. And what it is a fusiform swelling of a single digit, such as a finger or a toe. And this usually takes weeks to resolve. This is not something that happens overnight and then resolves the next day. Again, this can be seen in a variety of conditions as well. Acute sarcoid can also cause cystic bone lesions. So if you see, this is a picture of a right hand. So we see the right thumb and the right index finger there. You see this kind of lacy reticular pattern that's there in the joints. It should be a nice, even kind of smooth, white, homogeneous pattern. And this is kind of showing the involvement of the sarcoid and the granulomas and whatnot in the active inflammation. And we call this lacy-like pattern a reticular pattern. And this can be seen in sarcoid. So the presentation I was discussing with you earlier called Lofgren's syndrome, this is a condition, a very common presentation of sarcoid that has a really, really good prognostic outcome. The three pillars of Lofgren's syndrome are what they call hilar lymphadenopathy. That means big lymph nodes in the hilum area, right, in the chest area. So sometimes we can see this on a chest x-ray if it's big enough, but oftentimes we need a chest CT to really be able to discern the enlargement of these lymph nodes. You can also see abrupt onset joint swelling. The classical presentation in Lofgren's syndrome is going to be both ankles. So this is not the kind of fluid that is in the ankles when you've been standing up for a long time. This is the patient is waking up with them, and it's really, really localized kind of in the ankles. You're going to see warmth, redness, and pain with like when they try to move their ankles and try to do kind of circular motions with it. The last feature of the triad is called erythema nodosum. This is not specific to sarcoid at all either. In fact, it can be seen in multiple different kinds of infections, just to name a few: HIV, tuberculosis, hepatitis, even strep can cause this. This can be caused from oral contraceptives. The list goes on and on. In conjunction with the other findings, it is consistent with sarcoid, but by itself, erythema nodosum is not indicative of sarcoid or any other disease state for that matter. This is another syndrome, given a special name called Hereford syndrome. And these patients also have that kind of acute arthritis, so swollen, tender, red hot, inflamed joints, and they get enlarged parotid glands. Parotid glands are glands that kind of sit near your jaw. If you've ever bit into something super sour and you get that kind of pinch, those are your parotid glands. They're going to kind of excrete saliva. The sarcoid, the granulomas, end up embedding themselves and attacking these glands and causing inflammation there. So it looks quite like this young lady has mumps there. Because of that inflammation, the nerves that are traveling down the face can also get pinched and cause a facial nerve palsy, and one may present with inability to kind of move their, almost like a Bell's palsy, like an inability to move some of their facial muscles. And uveitis, which can be seen not just in Hereford syndrome, but any form of sarcoid. Uveitis is inflammation of the uvea, which is a lining kind of around the eyeball, and most commonly is referred to as anterior uveitis. It can also be called iritis, but there are posterior uveitis and panuveitis, meaning inflammation in the entire uvea. Again, not completely indicative of sarcoid by itself, but can be seen in a constellation of findings here. And moving on to bone sarcoid, these patients will present again with that tender, abrupt onset tenderness, pain, swelling. About 50% of the patients will be symptomatic from that. It's usually bilateral. If you remember that kind of diagram that has the red dots on it, so you're usually going to kind of see a mirror-like fashion. So both wrist, both knuckles across here. It can go to the spine as well. So when we say axial spine, we're talking about like the cervical spine all the way down to the lumbar spine. And appendicular refers to the hands and feet and any other digits as well. And these are the same, that cystic bone lesion that you can kind of see, that lacy pattern. We call this reticular pattern. This can be seen on radiographs, but MRIs are really great at picking this up. You can see kind of like this inflammation on a 2-2 flare. It's still non-specific. It doesn't tell us what the inflammation is coming from. It just tells us there is inflammation. Inflammation on an MRI could be anything from malignancy to infection or an autoimmune inflammatory process such as sarcoid. CTs are good at finding like the lymph nodes that I was showing you with that hilar lymphadenopathy, but they're not as good for bone involvement. So the tests of choice are usually MRI, and if need be, we can also do PET scans as well. They're quite sensitive for detecting bone involvement in sarcoid. In sarcoid myopathy, myo refers to muscles. Pathy means problems or abnormalities with. So sarcoid can cause abnormalities in muscles as well. There's a condition, there's several conditions in rheumatology that are called autoimmune myositis, meaning inflammation of muscles. These are polymyositis, dermatomyositis. Some features of sarcoid can often mimic these conditions as well. And so because they mimic them, it's going to be like the proximal muscles. And what we mean by that are those large muscles near kind of the body's center line. So biceps, triceps, the deltoids, the shoulder kind of muscles, the thighs, the hamstring, the buttocks, the kind of hip girdle. Those are the most common presentation. Less common, you'll see like the eye muscles, muscles around the ribs and whatnot. It's rare to see this as an initial presentation of sarcoid. It can be seen in conjunction with everything, but the only presenting feature would be much more rare to see that. It can occur subclinically, which means is a fancy just term for it's going on, but you don't really have symptoms in about 50 to 80% of the cases. And in those situations, it's a much more kind of an insidious, chronic, smoldering in nature. And this myopathy also gets broken down to 3 different subsites. So acute myositis, acute again means kind of abrupt presentation with inflammation, chronic meaning it's been going on for several months, and that's the most common form. And there's also a nodular myopathy. This is the most rare form of sarcoid myopathy. So this is that diagram I had to show you what the word, when we say proximal muscles, we're talking about all those muscles in red. And again, this is very similar to another rheumatic condition called dermatomyositis or polymyositis. So they have a similar presentation. And so in acute myositis presentation of sarcoid myopathy, we will see those muscle enzymes rise. And so we can do blood tests for that, right? And some of these muscle enzymes are called creatinine kinase, aldolase, and you will see elevated numbers. Typically, lab reports your reference ranges will be up to 150, 200. In presentation with like autoimmune diseases, they can be in the several thousands. Because of the pain and swelling, it can lead to a kind of perceived weakness because of the pain and swelling there. But unlike this autoimmune disease, polymyositis or dermatomyositis, we see some muscle swelling. We actually see enlargement of the muscle, right? So each cell is kind of getting enlarged and what we call hypertrophied. And there's some stiffness that occurs, and if it occurs long enough, you can develop kind of contractures where the joint or the limb is kind of flexed in a certain way, and we cannot kind of release that then. Other features is they could have joint pain in multiple digits. So when you have joint pain in more than five or more digits, we call that polyarthralgia. They may also present with that erythema nodosum. Remember those tender red knots? They're usually located on the shins, but they could kind of be anywhere in the body. We saw that with our Lofgren's presentation. And of course, you can have non-specific symptoms like fever, fatigue as well. If we do a biopsy, we see something very different than what we would in the other autoimmune myositis, right? The other autoimmune myositis is not going to show non-caseating granulomas, right? Granulomas are one of the hallmark features of sarcoid as well. So we can sometimes see that on the muscle biopsy, and that's what that picture is depicting there. In chronic myopathies, right? So this is the most common form. This is that slow, insidious presentation. And this can be tough to kind of pick up because there are other things that can present this way, things that can mimic this presentation. There's something called steroid-induced myopathy, where the steroids actually make the muscles kind of weak and maybe painful and stiff. And maybe there's muscular dystrophy. So there's a lot of things that can mimic this. It's also usually symmetric, and it's also still involving those proximal muscles. So the distribution is the same. In this form, we can also see trouble swallowing as well. The blood tests, the muscle enzymes, they can be actually normal in this. Remember, when it's acute myositis, it's an abrupt onset and there's going to be an elevation in muscle enzymes, but they can be normal to mildly elevated in this case. And on biopsy, it's actually quite similar to the autoimmune form of myositis. And so you have to kind of look for sometimes the granulomas and other features to distinguish the two diseases. Long-term, this condition, if kind of led untreated without physical therapy, can lead to contractures, remember, like flex joints, muscle wasting, which we call atrophy. And this is the least common form of sarcoid myopathy. It is called nodular myopathy. This is basically, if you can imagine, somebody is laying down flat in the MRI machine, and we are taking kind of cuts this way. The MRI is taking cuts. And if you cut it right here, and then you're looking up at their legs, right? So we're looking up at their legs. These are their thighs here. And this area here is all skin and the fat layer, and then into here you get into the muscular layer. Muscle should not be white. When there's white on an MRI, it suggests that there's water there. When there's water, it says that's edema and usually inflammation there. So we see this is nodular myopathy, and this is what is kind of circled here. So this would be abnormal. And they can also have these like tender nodules that you can kind of feel these, right? And so the patient's like, I feel something under there. They're usually in the lower extremities, and this is an MRI, and this would be the test of choice to investigate if you were suspicious for one of these. I love this slide. I think these pictures are, they're just kind of named really cool. The first on the left is a PET scan, and it's called an FDG PET scan. But for all intents and purposes, what it is it's a glucose scan. So what it's doing is it's showing all the areas of the body that are utilizing glucose in a high fashion. It's very normal to see, obviously, we have a heart that's working, we have a liver, we have lungs that are working. So there's gonna be some normal physiologic uptake, but there shouldn't be this pattern. It shouldn't be so black and apparent. And they call this tiger man, because if you look at the muscles here, you can almost, it looks like striations, like the stripes of a tiger. And so they kind of call this tiger man, and it's kind of pathognomonic for sarcoid myopathy. The next is panda bear sign. This is not a PET CT, this is a gallium scan, so a different kind of radioactive like uptake scan. Around the nose, that's a normal physiologic uptake, but what you see kind of like around here, around the, where just below the eyes or around the eyes, those are the lacrimal glands of the eyes. And over here by the jaw, those are the parotid glands of the jaw. So it's basically saying these areas are inflamed too. We're going to talk about a disease in a little bit called sarcoid. And so you can see some manifestations of that along with sarcoid as well. So next we're going to go into some of the other rheumatologic diseases that can be associated with sarcoid, things to consider. There's a lot of them: lupus, Sjogren's, JIA, gout, psoriatic arthritis, vasculitis. This is not an all-inclusive list, but I thought these would be ones to we'd like to kind of touch upon today. So sarcoid and lupus, you can see hair thinning. You can even see what we call discoid lupus or discoid-like lesions in lupus. The same Jacquard's arthropathy that we see in lupus that we talked about before, we can also see in sarcoid. Lupus pernio is an interesting thing, and it got to be a very vogue term in 2020 because it's really just an outward manifestation. It actually isn't significant for lupus. It's very much a misnomer, and it actually isn't pernio. What pernio is, and that's why it was significant for COVID, is a vasospastic reaction for the blood cells. It's usually incited by cold or could be, viral induced. It was given the term lupus really came from the wolf, which is why I have a wolf pictured here. The Latin for wolf is lupus. And when they saw this pattern of rashes across, kind of the nose, across the cheek, and they said, it looks like that orangish rash that this wolf has. So they named it lupus. Later, a French dermatologist coined the term lupus pernio for the sarcoid lesions on the face that seem to have the same distribution as well. And so this is a gentleman over here who's got what we call cutaneous sarcoid, which was effectively treated. However, this is kind of not at its peak, but you can kind of see around his nose, a little bit on his cheek, and it was kind of like up into his, closer to his eyes in that same distribution. It doesn't have to be on the face. It can actually be lupus pernio, sarcoid skin rashes can be anywhere on the body. So sarcoid and Sjogren's. So this is what we were talking about earlier with the panda bear sign. Sjogren's is a condition in where the immune system, the hallmark is the garden variety Sjogren's is where it's attacking the glands which make saliva and the glands that make your tear production. So the lacrimal glands in the eyes and the parotid glands in the mouth. And so the patients will present with what we call sicca. And that is dry eyes and dry mouth. And these are exorbitantly dry. The dentist is usually commenting on them. They're getting a lot of dental cavities for no good reason, despite good oral hygiene. And we distinguish this much on a biopsy. We don't need to biopsy the lacrimal glands or the parotid glands. It's a bit invasive. Sometimes we can just do a minor salivary gland biopsy. So if you kind of pull down your lip and catch a little bit of that tissue just inside your lip, on the left, you see normal salivary gland tissue. That's what that looks like. On the right, this is minor salivary glands of a Sjogren's patient. you see these islands of blue cells. These are called focus scores. It's for criteria, you need a focus score of at least 1 for the diagnosis of Sjogren's. But these patients with Sjogren's don't usually present with that thing called uveitis, which is that inflammation in the eyes. So if you see a patient with that, that's when we start thinking that's more likely to be sarcoid rather than Sjogren's. Sjogren's syndrome can be associated with high levels of 2 antibodies. When they have 2 names, it's called SSA and SSB. They're also known as anti-Rho antibodies and anti-La antibodies. There is caution with the use and utility of these antibodies because there are a lot of false positives in various commercially available labs. And there's also a lot of other conditions that can cause a positive SSA and a positive SSB. It's not specific for Sjogren's, so that can lead to some confusion. This is just here to highlight the American College of Rheumatology, as well as the European League for Anti-Rheumatic Diseases. They basically came together and came up with classification criteria for Sjogren's, and you're basically given points based on what features that you have, biopsies that you might have, blood labs that you might have. But you have to diagnose, exclude these other conditions listed below in order to achieve the diagnosis of Sjogren's. So you'll see listed on there is sarcoid. So a lot of these other conditions can often mimic features of Sjogren's syndrome as well. Next is JIA, which is juvenile idiopathic arthritis, and that basically has its own 6 subcategories. So these are children who present basically with the pediatric version of rheumatoid arthritis. And the classic presentation of JIA is this, what they call a salmon-colored evanescent rash. And it's evanescent, meaning it dissipates after a few hours, and it's associated with a fever. And if you plot a fever curve for a young pediatric patient with JIA, you'll see the fever will spike at the same time every day. And that's very pathognomonic for JIA. They can have rashes, dry eyes, uveitis also, so they can also present with some non-specific features as well. Vasculitis is not a very common manifestation of sarcoid. What vasculitis is inflammation of blood vessels. And vasculitis is a huge category within rheumatology. So it can affect small vessels, medium vessels, and large vessels. So large vessels are like your aorta, branches off the aorta like your carotids. The aorta is a major artery that comes off the heart that supplies oxygenated blood to the rest of the body. And at any level, we can have a condition called vasculitis, but the only time there's blood tests for vasculitis is what they call small vessel vasculitis. The other medium and large vessel, they have their own diagnostic kind of workup that's done. We don't usually see this with sarcoid, but it is a potential in the differential. But if you're seeing granulomas, nodules in the lungs, inflammation, big lymph nodes, vasculitis can do that too. In fact, the small vessel vasculitis, there are 2 major ones. The old terminology for those are Wegener's and Churg-Strauss, but now we do not use those terminologies. We call them granulomatous polyangiitis and eosinophilic granulomatous polyangiitis. So as the name tells you, there are granulomas present. So granulomas, again, are not just for sarcoid as well. We can also see this thing called ANCA. ANCA is an antibody that's seen in small vessel vasculitis, but in low amounts, low titers, low positive results, we can see those in sarcoid patients. We can actually see that in patients with chronic sinus disease even. So blood tests alone are not diagnostic of these rheumatic conditions. Sarcoid gout and psoriatic arthritis. So they have 3 major things in common. They all tend to present with elevated uric acid levels in the blood. They can present with abrupt onset joint swelling and joint pain. And you may have to, what we call tap the joint to distinguish that. And what does tap the joint? It means stick a needle into the joint. pull out the joint fluid. You're looking for crystals. If they're uric acid crystals, they're going to look needle-like under the microscope, and that would be diagnostic and the gold standard for diagnosing gout. If you do not see crystals in there, sometimes it's because you haven't looked around enough to find them, but if you don't see them, you're also looking for inflammation. So is there a lot of inflammatory cells? So we send the fluid off for testing, hopefully if we can get enough. And we also send it off for cultures to rule out any kind of infection as well. Things that psoriatic arthritis and sarcoid have in similar, they can both present with that uveitis. They can both present with sausage digits, also known as dactylitis. One of the hallmark features of psoriatic arthritis is something called enthesitis. The enthesis is the insertion point of a tendon onto bone. So you see this middle picture here. Here's a tendon. It's not necessarily the inflammation of the tendon, but where that tendon's inserting onto the back of the calcaneal bone, the heel bone, this is where the pain is, and this is where the issue is, and this is called enthesitis. If this has been going on long enough, if I get an x-ray of this patient, you will see the calcaneal bone, there's going to be some disruption of the cortex of the bone there. And they can also present with inflammation in the sacroiliac joints. This is another hallmark feature of psoriatic arthritis. And it can also be seen in sarcoid. The sacroiliac joints are a bit lower than your lower back. They're going to kind of sit just along your buttocks. And inflammation in these joints in diseases like psoriatic arthritis or ankylosing spondylitis can lead, for a long time, can lead to fusion. You can even have bites out of the bone called erosions and inevitably kind of joint destruction. And then it can be fused where the joint is not fully mobile then. And so we do see these in some cases that have, do they have a crossover? Do they have both conditions? Is it just what, it can be very diagnostically challenging at times. And just going to briefly touch upon treatments. So steroids are, the primary management for sarcoidosis. One, they work the quickest. And so it helps us get the inflammation under control. We mentioned the Lofgren syndrome, which was, again, that hallmark, that triad of the big lymph nodes in the chest, the erythema nodosum, which is those tender red bumps on the shins, and the inflammation of the joints, typically the ankle joints. That usually responds very well to either non-steroidal anti-inflammatories or short to medium courses of prednisone. And it usually doesn't come back, which is wonderful. Other cases of sarcoid may need more treatment. So we call these agents steroid sparing. Why steroid sparing? Because we want to spare the body from steroids. Contrary to popular belief, we actually don't love steroids. They just work and help our patients feel better very quickly. And the rest of the steroid sparing agents, unfortunately, no matter how old, how new, how cost effective, or how costly, they all take 2 to 4 months to be fully effective. So it's kind of a bridge to that therapy as well. One of the most common medications which is used is called methotrexate. Another medication that's used is called mycophenolate. It's easy to kind of confuse them. Methotrexate is also used in lupus. It's used in rheumatoid arthritis. It can be used in vasculitis as well. It's usually given as a pill, and it's taken once weekly. And it's also given with a vitamin called folic acid, because methotrexate can deplete while it's working to solve the problem. It can have a side effect of depleting the body's folic acid levels. So we supplement that with giving patients folic acid as well. It can come in an injection form if the patient's not able to tolerate it by pills. Mycophenolate is also another medication that can be used. Sometimes they're used together in some severe cases. If you're under the care of a rheumatologist, this can be done safely. Yes, it does increase your immunosuppression to some extent. Mycophenolate is taken daily. It's usually twice a day and can go up to 1,500 milligrams twice a day. This one does not require any kind of vitamin supplementation. Azathioprine is less often used in sarcoid, but is an alternative if a patient was not able to tolerate methotrexate or mycophenolate, if they were not responding to either of those medications. Leflunomide is another option. It's not as widely used in sarcoid. It's a very common medication for rheumatoid arthritis and works well for joint pain, joint swelling. It is a once daily medication, comes in 10 milligrams and 20 milligrams typically. And then lastly, TNF inhibitors. The one that's been studied the most is a medication called infliximab. I use infliximab a lot for our cardiac sarcoid patients. I work at a large health system and we have many cardiac sarcoid patients, and I work with a very astute cardiologist in advanced heart failure. By the time they're coming to me for a consultation, my partner in cardiology has already tried methotrexate and done the glucocorticoids, and he's saying, Pooja, I think it's time to try one of the TNF inhibitors. And so we usually do a medication called infliximab, which is a TNF inhibitor. TNF is a molecule, a cytokine of inflammation. These medications were first FDA approved for rheumatoid arthritis, and there are about 5 to 6 different kinds of TNF inhibitors on the market. There are also biosimilars now available as of the past couple of years. We have found with multi-drug resistant cardiac sarcoid that these TNF inhibitors work quite well for these patients. Okay, I'll go on to questions. I have some questions from that were already kind of posted, but let me just look through some of these and see if some of them overlap. All right, so what is, hang on, let me just stop a share here, sorry. What is a normal muscle enzyme? So normal muscle enzyme, I'm assuming you are asking about what is a normal reference range. A normal reference range is typically anywhere from like 50, 60, 70s to about 170, 200, and it varies from lab to lab. But again, in inflammatory autoimmune myositis, we usually see these 10 times higher. So we're seeing 2,000, 3,000, 10,000, 50,000 I've even seen. So that's kind of that answer. Will bone sarcoid always show up on PET? Yes, it really should, because even things like degenerative joint disease, which is osteoarthritis, does show up on PET as well. Okay, so it's gonna the PET CT. There's gonna be, you can think about it as a light that you're able to make dimmer, the dimming switch. Okay, so on a PET CT, there are going to be some things that are lighting up, but a little dim. There's going to be other things that are lighting up and very bright. So even normal, remember, normal physiologic activity is going to light up on a PET. So you have to, there has to be some kind of intuition. It's not like a black and white thing, but yes, that should be showing up. Is low dose naltrexone an effective treatment? I don't know. It's more, I think that would be a better question for a chronic pain specialist. Honestly, I haven't used that yet, but I know some rheumatologists have. And let me get some off of here. Mindy, you said the Q&A is different than the chat. Just want to
so I do have some. Okay. We do have some in the chat and some in the Q&A as well.
Okay, then let me come down here. I think I answered some of these. So how is bone or joint sarcoid diagnosed? So one is clinically, right? So if you're seeing some of those features that we were talking about, so if you're seeing those sausage digits, if you're seeing that that Achilles tendon kind of swollen and whatnot, so you're diagnosing it clinically. If there's a question as to whether this is happening or not, you need confirmation, then we do further imaging. What is it? Does Humira work for sarcoid? It depends. So Humira, for those of you who don't know, is adalimumab, and it is a TNF inhibitor. One of the challenges can be that it is not FDA approved. There's actually not any drug that's technically FDA approved for sarcoid, which is one of the challenges that we face sometimes. But I have seen it effectively done. Let me check some of these that were sent in. What are good treatments for musculoskeletal sarcoid? So if it's been confirmed, then you're kind of methotrexate's a pretty good drug for musculoskeletal sarcoid. Remember that this is a drug that is used, it's still drug of choice for rheumatoid arthritis. So if it's good for the rheumatoid arthritis patients to combat sarcoid, acute, joints pain, joint swelling, it works pretty well for that. How do I deal with the pain and stiffness associated with that? A lot of times pain and stiffness is a sequela, an aftermath, if you will, of things that were happening before. So a lot of aggressive physical therapy and myofascial release exercises that can be anywhere from like a foam roller, stretching. There's a lot of kind of like strategies that our physical therapist colleagues are very good at kind of helping us with. And the non-pharmacologic management of musculoskeletal sarcoid. So along with PT and physical therapy, there's topical agents that can be used too. And that technically isn't not non-pharmacological, but topical agents have a much better and safer side effect profile than any kind of oral agent, including like Motrin and Aleve. So these are things like Voltaren gel. Voltaren is actually diclofenac gel. Diclofenac is actually a very potent anti-inflammatory. All anti-inflammatories, when taken by mouth, if taken long enough, there's risk of increased cardiovascular events, stomach ulcers, and kidney damage happening. So if you're able to apply that topically, there's basically little to no systemic absorption from that. So that's a really great option. Do steroid injections help? They might. It might be short-lived. It kind of depends. If something else is not there to cover the disease systemically, then it may or may not help. One thing to consider, though, is certain joints are prone to things like osteoarthritis. Yeah. So osteoarthritis is like degenerative joint disease, the wear and tear type of arthritis, not the autoimmune type. Very common in the neck, lower back, knees, hips, weight-bearing joints. So it is important to distinguish which of these two things could be happening. Now, steroid injections are used for management of osteoarthritis pain as well. They don't put the joint space back together or fix the joint, but they can alleviate some of the pain. So similar to that, yes, potentially steroid injections could help with sarcoid. There was a question about vitamins and supplements. Nothing specific to sarcoid. However, a supplement called curcumin or turmeric. So curcumin usually makes up about 2 to 6% of turmeric. So if you're buying like turmeric capsules, you're going to look on the back to see how much curcumin is, and you're looking for about like 400 to 600 milligrams, and you can take that up to twice a day or 3 times a day. You can do that for sarcoid. You could do that for osteoarthritis. You can do that for rheumatoid arthritis as well. If you prefer the more natural form, you can also buy the root itself and grind and powder it up. You can take about 0.5 gram to 1 gram a day. You can go up to 3 grams of curcumin a day. Let me see here. How do I distinguish non-serological rheumatoid arthritis and musculoskeletal sarcoidosis? Very good question. So non-serological rheumatoid arthritis, we call seronegative rheumatoid arthritis. So not zero negative, seronegative. The serum is negative for rheumatoid factor and CCP antibodies. So these are rheumatoid arthritis patients that don't have one of the 2 lab markers for rheumatoid arthritis, but they still have it. So the way we diagnose this condition is a really good history intake. Really, the patient will tell you what's going on. We just have to kind of confirm it. And we'll either get like an MRI or an ultrasound to see, do you have inflammation in the same areas as any other rheumatoid arthritis patient does? And if so, then it's most likely that you have rheumatoid arthritis. But with musculoskeletal sarcoid, you're looking for more, right? You're looking for more signs than just joint pain and swelling. And so that would kind of distinguish the 2 of them. Again, you're looking for, do they have like the big lymph nodes? It's a systemic condition, sarcoidosis. Do they have eye involvement? Do they have skin involvement? And that's basically what you're kind of looking for. How often is musculoskeletal sarcoid diagnosed? It ranges from different reports you'll read. So anywhere from 5 to 40%. Just joint pain can be in 10 to 15% of sarcoid patients. Chronic arthritis is usually less than 2%. Bone sarcoid is about 5% of the sarcoid patients. The muscle disease, subclinically, as I told you guys, it can actually happen in 50 to 80% of the cases, whereas symptomatic disease is usually less than, where people are really having muscle symptoms, and inflammation is usually less than 2%. Do the lesions ever go away? I'm assuming this question is like the bone lesions on the x-rays. There's been case reports of spontaneous resolution, and you can treat the lesions with steroids and it'll reduce the pain and swelling and one will feel better, but it doesn't necessarily resolve the lesion on imaging. Another example of this is calcified granuloma. So these balls of inflammatory cells, sometimes we find them incidentally. Sometimes somebody was doing a chest CT for, you know, some other kind of workup that they were doing, and they end up seeing calcified granulomas. When you see the word calcified, it tells us it's old, it's inactive. There was a process happening, but it's long gone. And that is just like a marker of something that was kind of there. Can it get into the bone marrow? Yes, it can. It can get into the bone marrow. And we do see that on PET imaging. And we see that on an MRI is also very sensitive to that. And what happens when it gets into the bone marrow is that your bone marrow is where all your blood cells are kind of made, right? So the bone marrow makes stem cells. And then stem cells give rise to white blood cells. They give rise to red blood cells. They give rise to platelets. So if it's in the bone marrow, you could potentially see those cell lines kind of decreasing. And you would see this on a lab report called a CBC, complete blood count. It's tricky because white blood cells, they can be a little bit normally low. We call that normal African-American variant. We can see that in African-American population. These cell lines could also be low from some of the medications. Methotrexate has the potential, mycophenolate, azathioprine, leflunomide, they all have the potential to decrease any of those cell lines. So there has to be, you know, a bit of logic in terms of like a diagnostic approach to this. Looking at the timing of when the medications were started, then doing some imaging, if warranted, is a bone marrow biopsy kind of warranted, and that would be the gold standard of diagnosing that. Let me see here. What is a recommended diet for people with musculoskeletal sarcoid? It's nothing super specific to sarcoid. I know a lot of people want to kind of hear something differently, but we don't unfortunately have something super specific. But in general, it is kind of what we call an anti-inflammatory diet. You know, stamp of approval from the American Heart Association, the Arthritis Foundation, and these are lean proteins, staying away from like red fatty meats, healthy fats with omega-3 fatty acids like almonds, walnuts, salmon, the avocado, these types of things, and eating. I always tell people colorful food, right? Like in their natural state, and the more colorful your plate is, likely it's very healthy, right? So getting lots of fruits and veggies that have a lot of antioxidants and kind of fighting capabilities there. So again, nothing super specific, but this is really what, you know, kind of everybody we should all be doing and hoping to achieve in our families and in our friend circles. And it's not always easy, but nothing, you know, nothing super specific. Let's see if I missed anything on here. Okay, let me go back to this one. Can vaccines initiate the inflammation of granulomas? Anything can. Yeah, any stressor on the body, technically. So could a vaccine do it? Sure. Could you getting pneumonia or any other kind of like viral like illness, any kind of, you know, if you went in, you had a heart attack, any stressor technically can. We still do not know what causes autoimmune diseases, right? We have some leading theories. I tend to believe there is kind of a two-step kind of hypothesis where one, there is something about a person's genetic makeup. That's the first step. That is a little bit unique, but it's until like something sets that off until you actually have the outward manifestations. So that is still a little bit poorly understood. Here is a recent one. For patients receiving aggressive treatment with neurosarcoid, is the recent development of pain in the shoulders and hips likely be due to sarcoid or polymyalgia? I'm 68 and these are new symptoms. That's a very good question. So his question is, am I developing another autoimmune disease? Polymyalgia is different from what I was talking about, polymyositis. These are two different diseases. Polymyalgia rheumatica is a disease. It's a diagnosis of exclusion. It's an inflammatory condition, and you have to be a minimum of 58 to qualify for this disease. It causes severe, but it's not so much pain, it's stiffness. It's stiffness. It's a perceived weakness and stiffness in the shoulders and hip girdle. for you, I think if this is a question, you should probably be seeing a rheumatologist to ask this question, because it needs to be kind of diagnostically worked up. It would be unusual if you are on treatment for neurosarcoid to then develop polymyalgia rheumatica. So that might make it a little bit strange. So is there any other kind of explanation kind of from the pain? But I think that would be a good referral for rheumatologist. Let me see here. What is considered higher uric acid levels? Again, that varies from lab to lab, but most labs, the upper limit of normal is around like 8 or so, but it's not specific. So serum uric acid levels just on lab tests alone don't diagnose gout. The gold standard is getting the uric acid crystal, and they're like needle-like shaped, getting that, and it's microscopic, getting it from the joint fluid. You can clinically diagnose it if the symptoms kind of present with the right cadence, and you can kind of, if there's a spike, a really high uric acid level. Sometimes these patients are also on cardiac medications that end up increasing serum uric acid levels. So sometimes we can work with the cardiologist to maybe switch a blood pressure medication that might be helpful in excreting more uric acid out. Let's see here.
Oh, Dr. Singh, I just want to
Yeah.
bring the you have 5 minutes for more questions. So I'm happy to read them off to you as well, but you're doing a great job on just
trying to get through as many as possible.
We do have some questions about whether or not people should see a rheumatologist. And I wonder if you might talk a little bit about sort of what indications. I know a lot of our patients see only a pulmonologist or only a cardiologist, and maybe they're experiencing some of the symptoms you talked about, and when it is time to seek out a rheumatologist. Yeah, no,
that's a great question. So I tell patients when they come to see me that they can kind of consider me as their sarcoid quarterback, right? And so I am the person that when you see me, I'm not just going to be talking about joints because I'm a rheumatologist. I'm actually looking at the entire picture. So I will ask you from head to toe, you have rashes. Have you seen an eye doctor? Is there inflammation? Do you have any sores in your mouth? Do you have this? Do you have that? And then from there, sometimes I determine, well, you haven't seen a cardiologist, but I feel like you should, right? And I can kind of figure out, and I may need to rely on some other referrals to figure that out. So when do you need to see one? A little bit of that depends. Majority of patients are going to be with a pulmonologist because that's the most common presentation is with shortness of breath. If the pulmonologist is comfortable kind of doing that, it can be a little bit based on style, right? If they have a lot of experience doing this, if they're very comfortable, they feel like the patient's symptoms are under control. However, I don't think any pulmonologist or cardiologist would be opposed to any of their patients saying, hey, I also want to see a rheumatologist. I want to make sure I'm not missing anything here. They would welcome that, and collaborations are always most helpful for you, the patients, in the end. And so to answer that question is anytime you have that question, you should absolutely go at least do a consultation. You can do that once, and the rheumatologist might say, this is great. You actually just have pulmonary sarcoid. So unless these manifestations arise that I just asked you about, you don't need to come back and see me unless your pulmonologist has any further questions. Mindy, was there anything else?
Yeah, we do have a couple of people who asked about fibromyalgia, and maybe not a specific question, but just a question about like the difference potentially.
Yeah, that's a good question. So fibromyalgia is some paradigm shifts here to break some paradigms. It's not an autoimmune disease. It's not an inflammatory disease. It is not a disease that causes destruction to muscles, tendons, joints, body, but it can feel like it is causing destruction. So it can be very nebulous sometimes, and especially when you have a rheumatic condition like sarcoid, like rheumatoid, like lupus, to then discern which of these conditions is kind of acting up right now. And sometimes we have to kind of take it to the experts and work with your rheumatologist and, to figure out what is flaring. So it can be in some patients and as a second kind of disorder, if there's no direct kind of linkage, if you will. And the treatment for fibromyalgia, there's no rheumatic medications for it, unfortunately. There are a couple FDA approved medications. In reality, they do not work that well for very few patients. They will have some benefit with pregabalin or gabapentin or Cymbalta, and that's a huge win when that does happen. But a majority of patients do not find full effective relief with many of these medications, but it ends up being that we need to lean in on expertise of our pain management colleagues, psychiatric colleagues, behavioral health colleagues, not for psychiatric disorders, but just because a lot of the medications used for mood stabilizing actually are approved for chronic pain as well. And so while Cymbalta is approved for chronic pain, there's nothing to say that others in that same category might be more effective for you. So we need to kind of lean on expertise of other individuals as well.
Great. Well, Dr. Singh, we are going to close the webinar because we do have some last minute things to talk about. I just want to say thank you so much for this and for your expertise and this really great presentation. As a reminder to everyone, we will make the slides available in a locked PDF that's sent out after the event, as well as a recording of the video. So you'll have that as well. I just added a bunch of links in the chat for folks because we are going to say thank you to Dr. Singh and close the webinar. So thank you so much for that. And I just want to give one more thank you to our sponsor, Mallinckrodt Pharmaceuticals, for their support. And just remind folks that we really do value your surveys that you send us. It makes a big difference in how we continue to put out these events and this programming. So we do encourage you to complete the survey. Once you close your browser window, it should automatically take you to the survey. Please share how you feel the webinar went, and we'd love to hear your feedback. Additionally, there are more events before the end of the year. We encourage you to check them out and register for our additional educational and wellness events. And if you haven't already, please do join the FSR community. We do have a community link there. You can join the community. Make sure you stay up to date on all of our events and our activities and research opportunities. I also want to share with folks, we do have an opportunity to become a global sarcoidosis clinic volunteer leader, and we have 36 FSR Global Sarcoidosis Clinic Alliance members across the country. So if you want to learn more about how to get involved with FSR and check out these unique opportunities, please visit the website, and the link is in the chat there. Finally, we must also thank our donors for their continued support of FSR. We cannot provide programming such as this webinar without support of our generous donors. So if you'd like to help us ensure that this kind of programming remains free of charge for all patients and their supporters, we hope you consider supporting FSR. We have a variety of ways to do so. You can find out more via the link on our webpage. Thank you guys so much for this great webinar, and have a great rest of your day.